scope of the scope of today's topic is basically your nausea, vomiting, uh, management of nausea, vomiting, hiccups, constipation, and malignant bowel obstruction. Next slide, please. So, coming to nausea, vomiting, I'm sure all of us have experienced it at least once in a lifetime. So, how does it feel? Is it very pleasant? Is it a good sensation to have?
No, ma'am.
Absolutely not. It's like horrible, especially the afterburning that you get after the vomiting episode. Next slide, please. So it's as so because of this, we understand that we need to manage it properly. We need to manage it as soon as possible so that it helps in the overall well-being of the patient. Um, so there are two ways to do it. We can identify what is the triggering factor or what is the causative factor and treat that said cause or remove that triggering factor. Or we identify which pathway it is acting via and then block that pathway if we can. Next slide, please. So what are the causes? One more click. So there are three basically divided parts. Next, so above the neck, below the neck, and systemic causes, and these are called as the M's of emesis. So above the neck, as you can see, it is either metastasis or mass, any mass, meningeal irritation, migraines, or any other headaches, movement related, which is basically what you would call that motion sickness. Below the neck, again, masses or metastasis may lead to emesis. Motility related. So decreased gut motility can sometimes lead to nausea and vomiting. Mucosal irritation, obstruction, MI, maternity. Systemic is either mentation related or anxiety related. Systemic medication, any infection, especially in gastroenteritis, and metabolic causes, which can again lead to a lot of nausea. Next slide, please. Another simple way of remembering is the vomiting mnemonic. So it is basically vertigo or vestibular cause, obstruction or constipation, motility dysfunction. Again, with the inflammation, toxins, which include the medications, intracranial lesions, or intracranial causes, your nerves and anxiety, or any oral disorders. Next slide, please. So what are the pathways? Basically, the two centers that we are looking at is the chemoreceptor trigger zone and the vomiting center. Vomiting center falls outside the blood-brain barrier, while the chemoreceptor trigger zone lies inside. Next slide, please. From this pathway, we come to know the rest of the two are cortex and vestibular, which I did not mention, but the main what you call the centers are the vomiting center and the CTZ. The rest of them would be periphery, vestibular, and cortical, basically where there are receptors for nausea and vomiting. So, given these pathways or given these centers, we have the reciprocated neurotransmitters. Next slide, please. So, what are the neurotransmitters we are looking at? We are looking at neurokinin, we are looking at serotonin, dopaminergic, acetylcholine, your histamine, and your GABA. Next slide, please. So when we say the pathway, when you say that you identify the pathway and then block the pathway, basically what we're doing is we're blocking all these neurotransmitters. So we need to understand and know which neurotransmitters we are looking at and then give appropriate antiemetic. So your CTZ would basically have your dopamine and histaminergic or even your serotonergic system. Then vomiting center would have 5-HT3 predominantly and your NK. Cortex has GABA. Vestibular has your cholinergic and your histaminergic receptors. GI has your 5-HT3. Next slide, please. So once we understand the pathophysiology of the reason why there is nausea or vomiting, it becomes very easy to manage it. Next slide, please. So as I said previously, we identify what is causing it and treat the cause. So let's say there is constipation which is leading on to nausea, vomiting. You treat the constipation, automatically your nausea, vomiting would reduce. The second way of doing it is you identify the pathway and then block the pathway. So for example, if the patient is on chemotherapy or any disease directed treatment for cancer, you know they are uh, prone for nausea, they are highly emetogenic. So you first hand give antiemetic as a pre-medication before starting the chemotherapy. So it blocks the pathway so they don't have that sensation. It does not get triggered and they don't have any nausea, vomiting. Next slide, please. Is it clear till now? Any confusion, any doubts that we have?
No, ma'am, clear.
Okay, great. So coming to the rational approach for management, basically, again, as I said, the medication should be round the clock dosed according to the T half of the drug. So certain medications can be given once a day also, and those are fine. Others may have to be given thrice or 4 times a day. You have to titrate to effect. You need to see how much of a dose the patient is requiring. So it is very individualistic. You cannot give blanket dose for all the patients. Side effect profiles of every drug should be assessed and considered before starting the patient on the said drug. You should even check for any interactions the drug can possibly have with the other medications which are going on. And it is important to know that if one antiemetic is not working, let's say you've started the patient on domperidone or you've started the patient on ondansetron, if that said drug is not working, you need to give a medication which acts through a different mechanism. You cannot just substitute ondansetron for granisetron. Those act through the same receptors. So you need to have a drug which acts through a different mechanism uh, than the first one. Next slide, please. Uh, so coming to the non-pharmacological management first, there are certain measures which can be taken. Cognitive behavioral therapy, acupuncture, relaxation, hypnosis uh, can be given, especially when you know what the triggering factor is. So, for example, if it's a chemotherapy, they have something called as pre-chemo nausea vomiting. Like they just start puking their guts out 1 or 2 days before the said chemotherapy session. That is because they know that once they have been given the chemotherapy agent, they are going to vomit. So the brain sort of develops this thinking process that okay, I'm going to start vomiting, I'll start vomiting right now. So certain measures like your relaxation, hypnosis, and cognitive behavioral therapy would help in that. But again, these are a very long-term uh, plans. They need to be given over a period of time to actually have its work. Acupuncture relaxation would work a bit more faster than CBT. But again, you need to have expertise and trained personnel to perform those. Then the last three, that is avoiding strong smells, eating small and frequent meals, and supplements like ginger, etc. They basically help to elevate the triggering factors for nausea. So any nausea, so whenever you're asking a history of nausea, vomiting, you need to ask whether it is triggered by any smell of food, or is it that after eating the food they start vomiting. So oftentimes people will say every strong smell, the patient says that he's going to vomit and then he vomits. So in those cases, it's good to give them cold foods like maybe cold soup or biscuits and toast with chai if they prefer tea, coffee, whatever. So give them some dry snacks, dry cold snacks. Basically, toast would also work. This helps in taking off the nausea. And small meals. So small meals of less pungent smelling medications. That generally helps a long way to elevate nausea, vomiting in these patients. Next slide, please. Now, coming to the medications that we have antagonists of dopamine, we have serotonin, we have neurokinin, we have a prokinetics, that is metoclopramide and domperidone. We have our antihistaminic, which basically works well with the vestibular causes of nausea, vomiting, anticholinergic, steroids, and benzodiazepines. Next slide, please. So as we also, where all these are going to act, so dopaminergic are going to act on the chemoreceptor trigger zone, which is inside the blood-brain barrier. Vomiting center mostly has 5-HT3 and NK, which is outside, but again 5-HT3 has its role in the chemoreceptor trigger zone as well. Vestibular basically has your acetylcholine and histaminergic, and your GI has your 5-HT3 and some part of dopaminergic as well. Next slide, please. So let's talk about a case and then we'll open it up for discussion. You can put it on the chat box. So this is the case of a 70-year-old lady with advanced ovarian cancer. She's having increased abdominal pain since a couple of weeks. And there has been recent increase in the dose of opioids. And now there is constant nausea. What do you think is the triggering factor for her?
Ma'am, constipation.
Constipation. Okay. Anything else? Anything else that might be? You can type in the chat box as well if you want.
Might be taking tramadol, that's why nausea and vomiting occurs.
So opioids, basically opioids and constipation seem to be, we need more history basically, but from what we've got, it's either the opioids or the constipation that might be the triggering factors. Okay, next slide, please. So what do you think are the receptors that we need to target now? Okay, it's given already. So basically, most probably because they've specifically mentioned the increase in the opioid dose, it is chemoreceptor trigger zone that is getting activated. So we need either anything that would act on the CTZ. So that is either 5-HT3 dopaminergic or which would help more often. So here you would use a dopaminergic, that is haloperidol. You can give ondansetron also, that is not a contraindication. The only contraindication would be with either tapentadol or tramadol. Why? Because they have a they act on SSRIs or SNRIs as well. So tramadol has dual action on mu receptors and SSRI. Same goes with tapentadol. So if you give ondansetron, which is a 5-HT3 antagonist, it will kind of take away or reduce the potency of the drug. So if you're using tramadol or tapentadol, the drug of choice for nausea because of these opioids would be either haloperidol or metoclopropide. You would not want to go for ondansetron in these cases. Any doubts till now? Is everyone following? Okay. Next slide, please. So again, coming to another case, this is a 46-year-old female with diabetes and metastatic colon cancer. There is liver involvement and malignant ascites. Yes, I'll explain the drugs well. Okay. So there is liver involvement with malignant ascites. There is chronic nausea with intermittent vomiting. Reflux is there, bloating is there. Eating makes the symptoms worse. So what can be the potential reasons in this case?
मैम चूंकि लिवर इन्वॉल्व है तो उसमें यूरिया बढ़ जाएगा तो उससे वॉमिटिंग का हो सकता है.
Okay, so because of the liver. Okay, so that is one cause, liver. Anything else? What does reflux and bloating point to? Metastatic. Okay, so the metastatic colon cancer, the mass might be causing constipation, let's say. So which leads to reflux and bloating. So that is the reason. And eating makes the symptoms worse. So what does that indicate? Ulcers, okay. So ulcers or maybe gastritis, which is causing the nausea, vomiting. Okay. So what is the receptor that you're looking at here? Or which pathway, which center are you looking at? Are you looking at chemoreceptor trigger zone, or are you looking at vomiting center? Are you looking at peripheral or vestibular? One of the four. So which one are you looking at? Peripheral. Yes. Okay. One is peripheral. Anything else that we're looking at? Maybe CTZ also, because the liver, as you said, the liver is causing bilirubin and everything to rise, so it is causing nausea. So maybe the liver is causing the thing. So one is CTZ and one is peripheral. Now, which are the drugs which have effect both on the central and the peripheral? Two drugs that we give commonly. Which one would those be? Metoclopramide and ondansetron. Now, which would you prefer from either of them? Would you prefer ondansetron or would you prefer metoclopramide?
Metoclopramide.
Metaclopramide.
Okay, excellent. Why? Or rather, why not ondansetron?
Metoclopramide will induce, it is a prokinetic drug.
Yes, exactly. So basically, it will help with the constipation also and with the nausea vomiting also. Ondansetron on the other side, other hand, what it does is it's constipating in nature. So it might not every time, but it might aggravate the constipation also. So that might be detrimental to what we need to do. Okay, next slide, please. Again, you can give dopaminergic again here, but yeah, so either metoclopramide or haloperidol or 5-HT3, that is ondansetron. So haloperidol is basically a dopaminergic antagonist, right? So so they have the effect on the cortex and the chemoreceptor trigger zone. That's how they act as an antiemetic. Now, this is not the reason why haloperidol is generally given. It's an antipsychotic in nature, basically. That is what its primary use is. But it helps with opioid-induced nausea vomiting. It helps with chemo-induced nausea vomiting as well. Contradictions for metoclopramide have always been there because extrapyramidal side effects are associated with it. So a lot of time, if patients are sensitive to it, then you should avoid metoclopramide. So it depends again on patient to patient. That's why haloperidol is sometimes preferred over metoclopramide. But then availability of haloperidol might be the challenge that are faced for giving them. So if neither of them is allowed, then you have no option and you have to give ondansetron because you need to treat the nausea vomiting. So it depends on what is available and what can be given. Another drug which can be given is olanzapine. Olanzapine also work very nicely especially with chemo-induced nausea vomiting. Serenase. Usually Serenase is the brand which is very well known. It generally comes in the dosage of either 0.5, 1.5 mg. So my preferred starting dose is 1 mg. If 1 mg is not available, then I would give half of 1.5 mg. Serenase. Serenase is the name of the brand name. So tablet or injectable, both are available. Next slide, please. Another patient, 38-year-old male with metastatic melanoma, acute onset vomiting, which is worse in the morning. There is headache not associated with stiff neck. So what are the DDs that are you thinking of? What are the potential causes of nausea and vomiting here. Migraine, okay. Anything else? Gastritis, okay. Anything else?
मैम बीपीवी डिफरेंशियल डायग्नोसिस में
Sorry, I didn't get you.
मैम ब्लड प्रेशर इंक्रीज ब्लड प्रेशर
Okay. Yeah, maybe. Okay. Blood pressure, cervical region, cortical or chemo related, raised ICT, acidity. Okay. So here, because there is headache, migraine, as you said, and acidity as well. So those are the main things. But given it's a metastatic melanoma, I would go more for maybe a mass or a lesion in the brain or any meningeal spread. But then again, there is no stiff neck, so maybe the meningeal region a lesion is not there. Next slide, please. So raised ICT, as I said. So basically, we're looking at the cortical receptors now. So those are histaminergic, 5-HT3 or acetylcholine. Here, you can give either of them. So you can give 5-HT3, that is ondansetron. It will work very well, or hyoscine also will work very well. But dexamethasone will help reduce the raised ICT also. So it will help take out the cause which is causing the nausea vomiting. So dexamethasone would be the ideal management plan. But you can give ondansetron along with dexamethasone. So it has dual effect. Next slide, please. Okay, is nausea vomiting clear? Is there any doubt as such for nausea vomiting? So it's for nausea vomiting, it's basically is the pathway of how the nausea vomiting is getting induced, and that is how you treat it. So it's based more on the receptor profiles of the cause that is causing the nausea vomiting, and then accordingly antiemetic should be prescribed. It is not more of like, if this is the cause, then give this. If this is the cause, then give that. It's more of which receptor are working to cause the said nausea vomiting. Is that clear? Any questions, any doubts till now?
No, ma'am.
Okay, great. Okay, so coming down to hiccups, next slide, please. So, hiccup is basically the involuntary response that you get when there is expiration against a closed glottis. Next, just one more click. Yeah, so basically what is working is your abdominal and the thoracic viscera along with your diaphragm and the brain. Next slide, please. So it originates in the C3, C5 region and is near the respiratory center via the vagal. So basically the vagal nerve gets stimulated, and that's how you get the get that sound. Next slide, please. Just one more till the end of the slide. One more. Yeah. Okay. So it is basically a repetitive myoclonic contraction of the respiratory muscles and the diaphragm. And vagus nerve via the recurrent laryngeal nerve. So against a closed glottis, you exhale. That's how you get that hic sound. Next slide, please. So it is fairly common. You get it in 55 per 1 lakh patients in cancer, more in either central nervous or GI cancers. Sometimes it might be the reason for the diagnosis. So 20% of them present with hiccup when they are diagnosed with the cancer. Sometimes it is, many of the times it's because of the reflux diseases that they have. And it is as common as 3.9 to 4.5, almost 5% in advanced cancers. Next slide, please. So it can be acute, which is less than 48 hours, more than 48 hours, or it can be intractable, which is more than a month. Next slide, please. So what you're looking at, basically the causes for, especially for acute one, are a lot of carbonated drinks, alcohol, too much of food, fast, eaten very quickly, any emotional or excitamental state, sudden temperature changes, swallowing a lot of air while chewing, or chewing gums or candies. Next slide, please. Persistent or intractable, which lasts for more than 48 hours, basically. It can be because of a primary nerve damage or irritation. Hair or something else in your ear touching your eardrum can also trigger hiccups. A tumor or a cyst or goiter, your GERD, sore throat or laryngitis. Sometimes again, chronic or persistent can be triggered by alcohol, anesthesia, barbiturates, electrolyte imbalance, diabetes, kidney disease, steroids, or tranquilizers. Next slide, please. So it's basically a CNS disorder, which leads to a loss of control over the hiccup reflex. So it can be encephalitis, meningitis, multiple sclerosis, stroke, brain injury, or tumors. Next slide, please. So coming to the management, what we need to do is basically, if possible, take away the triggering factor. Next slide, please. Take away the triggering factor, or if that is not possible, then you do something to relax the diaphragmatic muscles or the intercostal muscles to reduce the frequency or stop the hiccups. So the first line would be your, according to the literature, the first line is your baclofen, gabapentinoids. Second line would be your prokinetics. Now, what generally happens, or what is seen in regular practice, is firstly you would try to figure out if it's because of gastritis or GERD, because it's one of the main causes for hiccups. So you give a good course of PPIs and antacid. Antacid by means of like Gelusil, Mucin gel, or Polykin gel as well. So give a good dose of PPIs, or if you want ranitidine or famotidine, whichever is preferred in your institute or which you prefer personally, plus a good dose of antacid in the form of Gelusil or Mucin gel. If that is not helping, then you add in a prokinetic in the form of either dopamine or domperidone or metoclopramide. If that is also not helping, then generally we give baclofen. It generally subsides with this. If not, then we go on to gabapentinoids. Next slide, please. Okay, so I'll be sharing the whole presentation with you. So that's not a problem. You can just take it from there. Third line is chlorpromazine, but again, so you generally stop by baclofen because that generally is when it should subside on its own. If it not, then a combination of all three of them should help. Others can be your anti-epileptics then, because you need to kind of calm the nerves down. So either carbamazepine, valproate, phenytoin, or your TCS. Next slide, please. Any non-pharmacological measures can be your nasopharyngeal stimulation with vinegar, or any irritant stimulant inhalation like smelling salts, ammonia, etc. Or oropharyngeal stimulation with cold water, or Valsalva maneuvers, which leads to a vagal stimulation, basically. Next slide, please. Your respiratory maneuvers as well. As I said, Valsalva, breath holding or rebreathing. Hypercapnia also sometimes help with acute. These are more helpful in acute cases, but it can be tried in chronic and persistent as well. Next slide, please. Am I audible now, or is it still not audible?
Ma'am, audible.
Audible, ma'am.
Okay. Previous slide. Okay, so other measures are hypnosis, acupuncture, nerve blocks, or vagal nerve stimulator or neuromodulation devices, basically. But again, you need expertise in all of these. So if it's available, you can obviously go for it and try it. If not, then the previous ones, which like smelling salts, Valsalva maneuvers, can be tried along with your pharmacological measures. Next slide, please. So coming to constipation now, is hiccups clear or was it confusing? I know it can be confusing from a pharmacological point of view, but generally you first assume that it is the gastritis which is causing it. You treat the gastritis. If that is not helping, you go ahead with the prokinetic. If that is not helping, then you go ahead with your muscle relaxants. Or even dopamine, like haloperidol can also be given if baclofen is also not working. So that is generally how you go. It can be mixed match. It can be like if you feel that it is chemo induced, then you can directly go for haloperidol as well, because that will cover the nausea as well as the hiccups. So you can go to and fro. It is not that you have to follow that path. It can be according to the patient and his or her requirement. Okay. Okay. So coming to constipation, next slide, please. So it's basically an incomplete defecation, which is either persistent, infrequent, or very difficult. Next slide, please. Can you tell me what a normal colon function is? What does colon help us to do?
Ma'am, water absorption.
Water absorption, excellent. Okay, anything else?
मैम salt absorption में भी help करता है.
Okay. और कुछ?
Vitamin B12.
Okay.
नॉर्मल
Yeah.
फ्लोरा जो मैम डाइजेशन में हेल्प करते हैं
Okay.
उनको.
Correct. So it's basically your electrolytes and micronutrients that are absorbed, your water, and it has a good microbiota. So nowadays microbiota is getting extrapolated in almost all the diseases. So that function is very important. Okay. Next slide, please. So what we are looking at, so this is basically the uh, uh, microscopic view. So basically you have your mucosa, you have your submucosa, you have your submucosal plexus, then your circular muscles and your longitudinal muscles and the serosa. So this is what we are looking at. Next slide, please. And so basically it is all about the fluid balance that we're looking at, because if that is deranged or becomes less or more, it will lead to either diarrhea or it will lead to constipation. Now, generally, approximately 2 liters of fluid is taken orally, plus you have your secretion. So a total of 9 liters is approximately comes to the gut. Majority of it gets absorbed in the small intestine. The last part of it, around 2 liters, gets absorbed in the rectum or the colon per se, and only 0.1 liter is pushed out uh, from the rectum. So of the total ingested fluid, only 0.1 comes out, right? So that's how you get a formed solid stools. Next slide, please. Next slide, please. So coming to the pathophysiology. So it can be because there is no, so the peristaltic movements, if you look at a normal peristaltic movements, basically what happens is as we saw the last slide. Okay, can you go to previous slide, please? One more. The presentation would be shared with you, so you can have a look at it as at your home also in leisure. So what we're looking at is basically there is a stretch reflex. So as the intestinal wall gets stretched out, your peristaltic movements start. That is the basic funda. Next slide, please. Do one more. Yeah. Okay. So anything that disrupts this peristaltic movements or this stretch in the luminal wall will have constipation. Now, there can be variations in this as well. So one is that psychogenic reflex disorder, like despite the stretch, the peristaltic movement is not occurring, or the sphincter is getting constricted instead of dilating itself. So that's why there is buildup of stools or constipation. So that might be one reason. Because of surgery, trauma, or any intra-abdominal infections, there can be paralytic ileus. That is like the gut goes into shock basically and does not do its normal function. So you have constipation. There might be something that is obstructing the flow of stools in the luminal wall. So it can be either intramural or extramural. It can be inside the lumen or outside the lumen, which might be causing the obstruction, like physical obstruction to the flow of stools. Any neurological disruption. So basically the nerves which are supplying to the circular and the longitudinal muscles, those are not working properly. So they might lead to either paralysis or abnormal movements or dilatation. There are certain drugs which act on the receptors in the luminal wall, like opioids or your 5-HT3s as well. So they basically slow down the gut, leading to constipation. And lastly, it can be the low fiber or low bulk forming agents in the stools or in the food, which would lead to uh, less quantity of stools that are being formed, which do not kind of stretch the luminal wall, which do not lead to good peristaltic movement. So that is what leads to constipation, and that's what we have to treat. So next slide, please. So according to what are the triggering factors, you need to address those as well. So other causes are your metabolic syndromes or endocrine syndromes like diabetes, thyroid disorders, or hypercalcemia as well. Neurological disorders like spinal cord injuries, your MS, Parkinson's, or any CVAs. Anorectal fissures or strictures, even inflammatory bowel disease can lead to constipation. You have your psychogenic, like depression or other eating disorders, drugs, as we said before, and surgeries, and dietary and lifestyle as a low residue fiber. Next slide, please. So non-pharmacological treatment, जो basically हम बोलते हैं, घर के नुस्खे, fiber rich diet, increase your motility, increase your fluid intake, and maybe if you can ritualize your bowel habits once a day at a specific time, you go and pass your bowel, like have your bowel movement. So these are the home remedies that all of us have been taught about. But again, this might differ from patient to patient. So it's important to ask in the history what their normal bowel cycle was before the disease. So like, let's say before the surgery, he was going once every 2 days, then that is his normal. So you cannot say कि oh नहीं तुमको रोज जाना ही है. So that might not be possible because his regular cycle was once in 2 days. So you need to ask that history while taking the history for constipation as well. Next slide, please. Coming to the pharmacological treatment, as we saw. So basically anything that is bulk forming to increase the bulk of the stools, which will lead to a good stretch of the luminal wall, which will lead to good peristaltic movements. Surfactants, especially with chronic constipation, what happens is because there is the water gets reabsorbed in the colon, a lot of fluid gets reabsorbed if the constipation is persisting. So the stools become very hard. Now, the problem with passing hard stool is that is very painful. So you need to either soften them using a surfactant so that it does not cause injury to the mucosal wall, or you put in fluid inside to make it soft. So you can either do surfactants, which are softeners, or osmotic agents, which pull in the water into the gut lumen and helps you pass the stools. Stimulant laxatives are basically to stimulate your peristaltic movements, and others like Pamoras, which are basically your peripheral antagonist of mu receptors. So these are basically preferred for opioid-induced constipation. Next slide, please. Okay, so bulk forming, as I said, bulk forming will increase the residue of the stool and also help in retain water. Stool softeners say soften up the stool so they are easier to pass. Lubricants basically make it soft and easy to again. So basically, they all of these basically have to help in passing the stools outside. So via various ways and methods. Next slide. So where they act and which are the drugs? So small bowel में castor oil, polyethylene glycol would help. Lubiprostone and linaclotide also work. Colon, basically bisacodyls, your senna substitutes, lactulose and your hyperosmolar salts. Next slide, please. We went through all this. So lubricants basically are your mineral oil enema or your glycerin suppository. So these are very helpful when, as I said, there are a chronic constipation that the patient has not passed stools for, let's say, a week or so. If you put in a glycerin suppository beforehand and then after, so usually with the suppository also, they generally pass the stools easily. What glycerin helps in doing is that it makes the stool soft, so it prevents the patient from having any fissures or tears in the anal opening. Usually they pass stools with just the glycerin suppositories, but if that is not working, then you can give in you can give like enemas or a stimulant laxative as well. Next slide, please. Motility. Then to increase the motility, what we have is basically your senas and the bisacodyl or enemas as well, because it will dilate the luminal wall, right? So the stretch reflex gets triggered, and that's how the motility increases. So bisacodyl and senna are the choice. What I prefer is bisacodyl because it can be given SOS also. So senna generally have to be senna also can be given as and when needed, but bisacodyl is generally what I prefer. It can differ for other people as well. Next slide, please. So what are the certain medications which cause constipation? Next slide, please. You should have put this up. Next slide. Yeah, so you have your analgesics like opioids specifically. You have your anticholinergics or your calcium channel blockers, non-potassium sparing diuretics, iron preparations, polystyrene sodium sulfonate, antacids, especially those containing calcium carbonate and aluminum hydroxide, barium sulfates, clonidine, ganglionic blockers, muscle blockers, or muscle blockers, ondansetron, or 5-HT3 basically. Next slide, please. Need to put in the. Now coming to an example, it's a 68-year-old male with stomach cancer, admitted for pain crisis. Previous home medications were diltiazem, Docuset, gabapentin, ibuprofen, morphine CR, codeine, and Miralax. Miralax is basically your polyethylene glycol. So these were the medications that the patient was having. Next slide, please. Admitted for pain crisis. Okay. So now opioid dosing is completed. He's on a controlled analgesia of pain. with no continuous infusion, but boluses are 2.5 mg every 15 minutes he can give it. Next day, the morphine requirement was around 70 milligrams, but he feels constipated. Last bowel movement was 3 days ago. What is the likely pathology that we are looking at here? Vacation during MOM. What do you mean by MOM? Okay, next slide, please. Morphine side effect. Morphine side effect, yeah, might be, but since 3 days. Oral morphine equivalent. OME is oral morphine equivalent. So, okay. So, the previous laxative regime was continued for him. 6 months later, suspected with ileus, opioid medication and bowel regime was titrated as an outpatient, but constipation was persistent. Milk of magnesia. Okay. Milk of magnesia might just lead to a lot of diarrhea. So you need to, that can be used, but again, not as a, like, not as the laxative of choice. That would not be my first choice. And many of the laxative, like clemafin and all, they do have, some of them do have milk of magnesia. So you might give it as a combination with other laxative, but not just that.
Ma'am, Bisacodyl.
Bisacodyl can be used, yes. Bisacodyl would be a, peristaltic agent, like a pro-kinetic sort of effect. Okay. So 6 months later, the patient lands up in the hospital again with suspected ileus. Constipation has been issue since then, but bowel regime was titrated as an outpatient. So here we are looking at morphine side effect, that is like opioid induced. Anything else that you feel might be the reason for his constipation, given that he has gastric cancer? So stomach cancer and on lots of opioids and other medications as well. Okay, here you can give Senna. Okay. But what are the causes for constipation here? Metastasis.
Less intake of water.
Yeah, so fluid and dietary fibers. So both of them are potential triggering factors. Okay, next slide, please. So bowel regime currently Docuset, Senna, polyethylene glycol, and bisacodyl suppository SOS. Tried with lactulose and milk of magnesia in the past, but no relief. So do you think, so here then, because you're treating all the potential reasons, it might just be because of the opioids that, as you said, morphine ka side effects. So do you think a peripheral antagonist would help? Like, as we mentioned there, right? Pamora. So methyl naltrexone is one of the peripheral antagonists of morphine. Unfortunately, not available in India. So we are not but yeah, that is one of the medicines that you can think of, methyl naltrexone or peripheral antagonist. Now, how peripheral antagonists differ from your central antagonist is that they do not have any effect on your analgesia. So methyl naltrexone will have no effect on the analgesia of morphine, but it will help take away the peripheral side effects like constipation and nausea. So that should go away. So that is one of the advantages of Pamoras over central or your antagonist like naloxone. Next slide, please. Okay, now coming to a 57-year-old female, stage 4 ovarian cancer. She has continuous and colicky abdominal pain. There is abdominal distension, no bowel movements in 7 days. There is nausea, vomiting, and the vomitus is a large volume vomitus with undigested food particles. And she has relief after the vomiting episode. Is it only constipation or is it anything else that you're thinking of here? Obstruction. Okay. Excellent. Yeah, so it points towards obstruction, like especially that large volume emesis that she's having. Yes, so compression of the colon. Next slide, please. So coming to malignant bowel obstruction, next slide, please. So it's basically, as I said, the obstruction can either be because of an external pressure on the colon or internal mass which is obstructing the flow. So mainly seen in abdominal or pelvic primaries, but sometimes can be a metastatic disease from lungs, breast, or esophagus as well. Next slide, please. So there are two, so large bowel or small bowel obstruction. It can be partial or complete. If it is an operable sort of malignant obstruction, then the median survival is around 6 months. If it's inoperable, then it comes drastically down to just 6 weeks. Next slide, please. Okay, so again, coming to the previous case. So we are talking about obstruction. So do you feel that it is an upper GI obstruction or a lower GI obstruction? How do you differentiate between upper GI obstruction and lower GI obstruction?
Ma'am, it's acute large volume emesis, undigested food
Yeah.
because
So
of
yeah.
upper GI.
Yeah. So the nature of vomitus basically, or the type of vomitus that they're having in lower GI tract, basically you have your it will not be a large volume, it will be a small volume with fecal matter sometimes present. Okay, next slide, please. So can you come till the end of the slide? There are a lot of arrows and everything. Oh, I'm sorry. Yeah, previous. Okay. I'm sorry, the arrows have come upper niche, but if we are looking at partial or incomplete bowel obstruction or complete bowel obstruction, so basically what happens is that the luminal contents start building up. So there is increase in the amount of luminal content present. What this leads to is there is stretch of the intestine, right? So because of the stretch, as we saw, what happens is because of the bowel distension, there is increased peristaltic movement. So bowel contractions will increase. But because the pathway is blocked, the flow of the content is not there. So this leads to the colic that they are having. So one is the because of the increased peristalsis or increased bowel contraction, there is colic because the flow of stools is not there. Another thing that happens because of the bowel distension is because it is stretching too much and because it cannot pass. Because of that stretch, there is pain. So that would be the continuous abdominal pain that the patient is having. So this is because of the luminal content. Now, because the lumen has distended, the mucosal area also increases. So basically the surface area of the mucosa increases. What this leads to is increased secretions of water and your electrolytes, that is sodium and chloride. Now, because of that, you'll have your nausea, vomiting, because there's a lot of secretions present in the bowel. Again, this increase in the secretions would again lead to increased distension, which would again lead to contractions, colic, and continuous pain. Now, because of the pain and because of the distension, there is an hyperemic status of the mucosa or the lumen of the gut. Because of this, there is an inflammatory response to it, which will lead to increase in the inflammatory secretions. So basically your prostaglandins, secretagogues, and nociceptive mediators, they would increase. Again, this leads to hyperemia and edema of the gut wall, which would lead to increased secretions of water and electrolytes. So it basically goes round and round in circles, and it all leads to your colicky abdominal pain, your continuous abdominal pain, your nausea, vomiting. Yeah. Next slide, please. So coming down to the treatment, now we have if it is a reversible and with a good prognosis, again differs from a partial obstruction to a complete obstruction. Next slide, please. Your non-surgical option would be to put in a NG tube because you want to give the gut a rest and you want to remove the excess secretions and fluids that are present in the stomach. So you remove that. If it is a good prognosis, like first time obstruction and you feel that it is reversible, then and the prognosis is good, so you can go for surgery with supportive treatment. If you feel the prognosis is not that great, but it is still reversible, you can give medical management or supportive measures along with the parenteral nutrition if needed. And if you feel that the prognosis is very bad and very poor, or the health of the patient is not good, then you can just go for supportive measures plus minus nutrition if needed, or if needed, a venting gastrostomy can also be done. Next slide, please. So, intervention. Sorry. Okay. So interventions, potential interventions that we can do is, like if it is a single level obstruction, you can go for stenting or surgery if possible. Non-decompressive interventions are your nasogastric tube or a venting gastrostomy. Venting gastrostomy basically is you're feeding gastrostomy, but instead of feeding, it is used to remove all the secretions in the stomach. So what this helps in is that the person can eat. So if he wants to just, taste food, if it's, sometimes they are like, yeah, I want to drink water through my mouth. I don't want saline, or I don't want TPN and all that. So this venting gastrostomy can be done. The drawbacks or the barriers for doing venting gastrostomy is that it's kind of expensive. Not everyone can afford it. The expertise is also not available in many of the hospitals. So you need to be very choosy while doing it, and it should not be done for all the patients as a blanket case. Next slide, please. Next slide, one more click. So basically what we have to do is luminal contents को कम करना है. So you need to reduce the luminal contents. You need to reduce the secretions in the bowel. Next slide, please. You need to treat the pain. So you need to treat the continuous pain and the colic. You need to treat the nausea, vomiting. Next slide, please. You need to reduce the inflammation also. So that is the target areas that we have. We have to increase the, you can go ahead. Yeah. So you need to reduce the pain. You need to give a prokinetic or decrease the lumen content. You need to give anti-secretories. You need to give antiemetics, and you need to give anti-inflammatories. Next slide, please. So it differs from partial obstruction to a complete obstruction. Coming to partial obstruction, basically the aim is to get the bowel to function in its normal potential. So anti-secretory would not be necessary here because the lumen is not completely obstructed. So it's not as if the whole content is getting accumulated in the gut. The secretions can have a space to just get out of that level of obstruction. So here prokinetics can be thought of. You can try a regime of a good laxative. You should give dexamethasone because it will help reduce the edema. It will help with the anti-inflammatory inflammatory process that is going on. It will help with the nausea, vomiting as well. Now, the antiemetic of choice should depend upon what your goal is. Now here, because you want to get the gut to start its movement, you can give a prokinetic, which will help with the nausea, or you can give haloperidol or dopaminergic because you don't want to slow down the gut further. So 5-HA3 can be given. It's not that you cannot give it, but it should be resorted as the last step instead of the first line. And here, because opioids are again a triggering factor, they slow down the gut and you want to increase the gut motility, you would want to avoid using opioids. Again, I said avoid. It's not that if it's necessary that you don't give it. It's just that you use it as at the minimal dose and as sparingly as possible. Next slide, please. For complete obstruction, then the goal is completely opposite. You want to shut the gut down. Shut the gut down in the sense you want to stop the colic, because which it would be very severe. You want to decrease the secretions. You want to increase the inflammatory process. You want to give a good antiemetic. Now, it does not matter if you give haloperidol or 5-HT3, because you want to decrease the gut motility here. And you can consider venting gastrostomy here. Now, why shut down the gut is because it's completely obstructed. Now, the obstruction can be, as I said, extramural or intramural. The goal would be, if possible, to open up the gut again. But if the colic or the pain persists, the inflammatory process persists and the secretions increase, and the whole vicious cycle just continues. So you basically have to stop everything to help the gut to open up again to start its function again. So you want to shut it down first, give it a rest, and then let it start its normal function again. Next slide, please. So coming to a case again, it's a 42-year-old female with cervical cancer. She has peritoneal carcinomatosis, admitted with small bowel obstruction. She is given metoclopramide, dexamethasone, haloperidol, and octreotide. Is it a good regime to have, or is it missing something, or is it having extra something that you would not want to have? Is the pathophysiology of malignant bowel obstruction clear? Okay, omit metoclopramide. Why? Any particular reason why you want to omit metoclopramide? You're feeling it's a complete bowel obstruction. Is that what you're saying? It's a complete. Okay, so if it is a complete bowel obstruction, you would omit metoclopramide. What if it's a partial bowel obstruction? What would you omit then? Octreotide. So basically, octreotide, you're giving it as an anti-secretory. It reduces the secretions in the gut. So that's the reason why you're giving octreotide. Okay, next slide, please. NG tube. Yeah, NG tube, I think it is a must, because it helps remove the excess secretions and gut content. Okay. So for continuous pain, as I said, if it's a complete bowel obstruction, you would prefer giving opioids, because you want to slow down the gut. You don't want that colicky pain. So anti-colicky agents that we have are either anticholinergic, that is either your hyoscine or glycopyrrolate, or anti-secretory, which is octreotide. Next slide, please. Nausea, vomiting, as I said, metoclopramide, but again, to be given only if it is a partial malignant bowel obstruction, and it should be avoided if the patient is having severe colic. So even if it is a partial obstruction, you should avoid it if the patient is having a lot of colicky pain. So you should avoid it then. Then, sorry about that. Anti-secretory, because it reduces the secretions in the gut lumen, automatically your nausea, vomiting reduces, right? Then hyoscine, again, it helps specifically with your colicky pain. also has an effect in reducing the secretions, so thus helping with nausea vomiting. And haloperidol, as we saw, it has a central action. It would reduce the nausea vomiting via the dopaminergic antagonist action that it has. Next slide, please. Then the common doses that we use. So anti-inflammatory, dexamethasone, usually you give in the dose of 6 to 16, or you can go up to 24 milligrams IV daily. We generally use hyoscine instead of glycopyrrolate. So glycopyrrolate is 0.1 to 0.2 milligrams subcut or IV 3 to 4 times a day. Hyoscine would be 20 to 40 milligrams 3 times a day, or titrated accordingly. Octreotide is 0.2 to 0.9 milligrams or 30 to 80 micrograms per hour subcut or IV. Metoclopramide, the usual dose, that is 10 to 20 milligrams Q6 hourly. Next slide, please. Thank you. Any doubts, any questions?
Thank you, Dr. Rutula. So now the forum is open for any questions or queries which you might be having regarding the session.
मैम आईबीडी के केस में क्या करें?
IBD के केस में depends on what the symptoms are, right? So what IBD in what sense? You would have to so they would be on medications of its own. IBD का medications चल रहा होगा, and according to what she is having, then you might have to give either a fiber-rich diet, or because there are variations. Like sometimes it might be constipation, sometimes it might be loose stools. So you have to titrate it according to what she's currently having. So IBD would be a very uh, for anorexia in cancer patients. So for fatigue and anorexia, there's not a lot of things that you can do. For anorexia, especially loss of appetite stimulant in the form of either your uh, S, um, NRIs, like your mirtazapine can be given. You can give appetite stimulant like dexamethasone also has a appetite stimulating property, or your cyproheptadate. It helps with the appetite, not so much with the weight gain. So that is another way. You can even give cannabis, like your cannabinoids are good appetite stimulants, especially in HIV and cancer patients. So those also can be thought of and tried. But again, the dosing with cannabis is very tricky. You will have to, and you get oils of cannabis now, so you can try those. Titrate it according to the side effect profiles and the response the patient has. So that way. Medications during pregnancy for constipation. You can give a fiber-rich diet or bulk forming. Because it's basically because of the compression over the lumen. So any stool softeners basically will help, or even like a stimulant agents will also help. Non-pharmacological would be maintaining your physical activity and fiber-rich diet again. So those are the non-pharmacological ones. Pharmacological ones would be your stool softeners or stimulant laxatives. How to manage tendency to pass stools just after food intake. So again, that brings out the question why that is happening. So sometimes it might be your uh, gastrocolic reflex that has been developed, like either because of some infection or increased gut sensitivity. So a good dose of your probiotics sometimes help. Uh, a fiber-rich diet again helps because it helps you form that bulk of the stool. So those also help. Sometimes zinc supplements also help in healing the gut mucosa. So in cases of diarrhea, you can use that as well.
Any other queries?
Those will have to be like lactose, and those have to be via a GI specialist. Like if they have, I mean, it depends if every time there is a triggering factor and you have the symptoms after particular dairy product or any dairy product, in fact. So those might be your leading cues, and then it's basically history taking and then doing the proper investigations to diagnose either celiac or lactose intolerance. So history taking would be more important in those cases. And sometimes nowadays, if the patient is having any chronic disease and have been on medications for a long time or have been off dairy products for a long time, they develop lactose intolerance despite not having it previously. So asking that history is important. Hypertension in pregnant female during first trimester. I'm not sure. Again, will depend on what is the triggering factor for the said hypertension, because usually there is increased volume during pregnancy. So again, multiple reasons for hypertension might be anemia related. It might be flu like decreased fluid related. So it depends on why the hypertension is, and then you would have to treat it accordingly. But yeah, generally you'll have to, I would want to refer her to a gynecologist to manage all this, because there are certain medications which you can and cannot give in pregnancy, especially the first trimester, which I to be frank, I'm not very well versed with. So yeah. But again, find out why she's having hypertension and then proceed with it.
I think if there are no more questions, maybe we can call it a day. Any closing words from you, Dr. Rutula, you would like to?
I hope this was helpful. And if you have any doubts, please feel free to reach out and I can help if 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 I can. So yeah.
Thank you so
Thank
much,
you,
Dr.
ma'am.
Rutula. Thank you
Thank
so
you.
much for joining us. We can definitely see that your throat is not well, and
Yeah.
till you found out time and you took us through the session so nicely. Thank you so much for that. Thank you
Thank
everyone for joining in, and with the promise that we will meet again with another eminent faculty and another important topic. This is Sri Priya along with Dr. Rutula Sonawane signing off from the Tipsy Home. See you in the next session. Till then, everyone take care. Bye bye.